So I use the CT to check what happened. Wow, what is this? It's from.
So it means that when you see the patient with a wound, with a perforated wound, and the symptom with the sign is not better, not get better after the first treatment. So we have to think about the foreign body. It's the possibility to have a foreign body, right? So any question and any comment, please? For all three cases, we found the foreign body by using CT scan, right? CT scanner. So what about the ultrasound? Do you think the ultrasound can help you to find out the foreign body in the orbit?
No, in literature, all the authors say that the ultrasound has no role. And in fact, on three cases, I also performed the ultrasound, but it only the ultrasound result also see that it has many high echo in the orbit, high echo lessons. This is not clean, and ultrasound will not show that it has orbital foreign body or not. What is its location? And it does not have any role in.
But I have a no experience also. But I just check if the ultrasound can find out something unknown in the orbit or not.
I think it can mimic the hemorrhage in the orbit.
Yeah.
Orbital hemorrhage. It can mimic high echo lesson.
So it means that the best one is CT scan or MRI.
CT scan because the first one you can rule out the metallic foreign body. You can use the MRI in the first one.
Yeah. So please, Dr. Van, you want to say something more? Dr. Van, please.
Foreign body is the orbital because it's rare but not so rare. It's pity that now Dr. Quốc Anh is not here because I see some patients at that time the patient already have a wooden foreign body and we already removed the wooden foreign body and we think that everything is okay. And then after that the patient come to the trauma consultation and very frequent. Because they have some swelling of the eye, and the patient always complains that he feels it's not good in the eye, and when he press on the scar, he saw some burrs on the scar. But after that, almost the doctor in the trauma consultation give them some antibiotic with the corticoid and said that everything is okay. You just only have a small abscess there and everything is okay. And after that 3 months later, the patient comes to the eye trauma department with the eye swollen. And at that time, even we do the CT scanner, we cannot find just only the patient he has like orbital cellulite, and we cannot find on the CT scan because this patient is 2 years ago, and I think Dr. Sơn maybe he don't get this patient. And after that, this patient come here with us with the orbital cellulite, but actually on the CT scan we can't see anything. But Dr. Quốc Anh decided to explore the orbital, and he found so little the debris of the wooden is already melted because it's a time.
I mean, that's very small space. Yeah, small piece.
Okay, and another case I remember with Dr. Quốc Anh because he already removed the wooden foreign body 2 times on this patient, but the patient always put under the systemic antibiotic and corticoid, but he returned frequently because he feels so
painful or
painful
something.
or something around like this, and at last the patient have to enucleation, and because the eye already affected, and then we can remove the foreign body. So I think he should, because as soon as you remove it, it's more easy to remove because there a little blood, the neurovascular to annulate around the foreign body is more easier to take it out. So that's why I told Mr. Sơn to present about this patient.
Yeah.
So it should be remembered that the patient have one foreign body, we already removed it, but with the wooden foreign body, maybe there's something left on the eye. No?
Yeah. Thank Dr. Vance. Dr. Point, I don't know, he may not hear. Yeah, Dr. Kun, please. Dr. Kun, could you please move to on this side so everybody can see you?
Thank you for your presentation. Yeah, it's remind me of something about my patient when I was working in the traumatology department. I have some patient like Dr. Van just mentioned. I mean that in the beginning part, the diagnostic not very hard because in the meantime you can do the investigation by medical history. You can explore that you can predict that if foreign body would metallic or something like that. But if a patient come to hospital quite late, with that very late, several months or 2 years, something like that. The diagnostic exactly I think be very difficult. At that time, access progression of the secretion or discharge from the eye in correct progression, and if the patient he or she did not recognize about the trauma accident or trauma context, so she forgot cannot determine this object, the wooden or metallic or something like that. And in CT at that time you could not find out clearly it's wooden or metallic. I mean at the time abscess, and you can find out some micro air bubble, and at that time you should do the MRI. It can make the diagnostic more exactly. And Dr. Sơn have do the anatomal historics carefully with the patient that mentioned, because logically for foreign body with a wooden foreign body can make the fungi infection. So the secretion of discharge, which best smell and chronic progression. And have you ever meet some patient like that? Fungi infection and the granuloma effect. I mean that around the foreign body. If you wouldn't in the anatomy histology, you can find out granuloma around the foreign body and fungi infection. Have you ever met the patient?
In the first case, we take the sample from the orbital cavity. We take the foreign body to the test, and the secretion from the orbital cavity for the test, and the test on the foreign body show it has the fungus, but in the secretion no fungus, and the culture was negative in both cases. In the literature, you have two largest case report and series. They also say that they cannot control any fungus on the case of wooden orbital foreign body. So that's evidence they do not recommend the antifungal therapy.
And normally we can make best, very bad scar and fistula. We will make the patient fistula in the orbit and it discharge or secrets and so long time. Fistula.
Yeah, when I was resident, I followed Dr. Quốc Anh. We have a case. He's have a prolonged infection and we have to perform about 3 or 4 surgery to remove the foreign body in the orbit. And each surgery we remove one piece of branch. After that, another surgery remove another piece, and so this patient have a very prolonged infection.
And after remove foreign body, you have meet the inside the drainage.
No,
by betadine or
we only rinse the orbital cavity with betadine. And if we have to suture the wound, we have to the suture, long suture to secretion can not too tight, and long suture to secretion can out can go out.
Well, how about oxygen liquidation? You can bring out the fragment body.
We only use betadine.
Oh, betadine.
Yeah.
Okay. Thank you.
Thank you, Dr. Kuhn. So, any comment or any questions? Professor Kuhn, you want to say something? You say yes?
I would like to ask the fungal infection Dr. Kuhn asked.
From Dr. Vân speaking, we can learn that for organic foreign body, it's more difficult than non-organic. Non-organic like a metallic or glass is not degraded by the tissue, by the body environment. But organic foreign body, it degraded. With the time, it becomes softer and softer. So it makes us very difficult to move it out. So can you share your experiences? How to take all of them out? What is technique to take all it out? Can you share it? Because it's very important to take all the foreign body out. You understand my question?
Sorry, it's not my field. And
Yeah.
this
Or maybe Dr. Sơn or Dr. Kuhn can share it. So you can learn. Yeah.
Department who
Yeah.
do about this
Yeah.
field.
So in the organic, especially the wooden foreign body, is really difficult to remove all completely.
Yeah.
And we think that if we perform the surgery, we must be very careful. We must separate the soft tissue very carefully and try our best to not use force to grasp the foreign body out. We must be very careful and gradually grasp the foreign body out. Also, we separate all the tissue surrounding it. Yeah.
So it means that we have to make the wound wider, right?
Yeah.
So we have enough space.
Yeah.
And we have to cut off the tissue surrounding the foreign body, and
Yes.
then we move it down.
Very
right?
carefully and gradually.
Okay. Thank you. What about the first cases? This one, and the patient remove all of the foreign body out, and after that the patient have a high fever, and we refer the patient to other hospital for systemic treatment. So do you have any information about the outcome of the eye after that?
In the first case, we performed surgery on the Friday. So on the Monday, when I examined the patient, he has no change on the eyelid swelling, and he also have the distress from the primary wound, and he also have a mild fever, 38 degrees Celsius. So we also perform the CT scan again. We check out if it has remained the foreign body in the orbit or not, and the CT scan results show that it's only the orbital soft tissue inflammation, and we decided to take the patient to the Bạch Mai Hospital. I think this patient have to treat the antibiotic therapy more aggressively, and in our hospital we only have the ceftazidime IV, and unluckily the patient until now don't come back to me and I can check.
But next time, before
Yeah,
the
yeah,
patient,
yeah.
you can take the telephone number and then ask about the
I
situation.
agree.
And then the patient, you can know about the eye, or you can ask the patient come back for eye checking. That's better, so we can see more. Yeah.
Thank you.
So, is there any question or any comment from Arya? No? Professor here, do you have any comment, please?
So, first of all, I would like to thank Dr. Sơn and also the traumatic department to present 3 cases of very typical foreign bodies in the orbital. And through each case that presented, we realized that sometimes the frequency or the numbers of the wooden body are not so many. But I think it's very important things that sometimes it's very difficult to identify. The first case, that's okay, 3 days. But the second case is 2 years. And we can see that even the foreign body stay there for years. Very difficult. From the patient side, they probably go not to right doctors, but from our side, we may not, identify, the foreign body. Even the first 2 cases is very dangerous because no vision at all. And the last case, I think, because the foreign body is light a little bit far away, not deep enough to affect the nerve, something like that. From my point of view, there's one factor we should pay more attention to in those cases. That's the history of trauma. For 3 cases, they all have, touch or hit with the 3 branches of 3 twig, something like that. For patients, they, come early to the doctors, we can ask them. But for others, like Dr. Kun said, sometimes they do not remember how, the trauma happened, something like that. Does need our, very patience when we ask the history. And the second thing, I think sometimes if we not, diagnose rightly, correctly, very dangerous, very dangerous. The patient have to come to us if there's infection occurs very often. And we also very confused about why that happens. Even we have a CT, even we have the X-ray, even we have ultrasound, but no rose. So that's need the experience, and I think that's the clinic sense. Say, when you work for a long time in this field, when you see some patient like that, of course, if you have another patient, that makes you to remember about the previous cases. And that's, I think, it's only those who work in this field, in trauma department, you have. But we not working there, probably we say ignore. So that's very important. And I also want to talk about the treatment. Of course, the wound stay for quite a long time. It's not intact, like melting, break down or in small pieces, and it's very important. It's very difficult to take out. But sometimes we don't know. So I think before performing surgery, and if you think of the wounded foreign bodies, I think you should say the best like instruments or best tool. For example, why we do not do the MRI rather than CT? Because if the patient have to pay some more, say in taking the MRI, it's better than say to be, you see, the suffer some surgery later on. And if we know exactly how many pieces, or say the real foreign body, it may guide us how to deal with, you see, the foreign body. I think better than just little by little. And sometimes we can't. For example, if the foreign body is so deep, probably we could not, because even we see it in the city or this, in pictures, but when we try to get it out, it's very difficult. We know that even, you see, other foreign body, even oculars, the foreign body, sometimes it's very difficult. Like sometimes we have the needle or some disease, small pieces that in orbital. Even we see it, we know the position, but very difficult to get it out. So I think with the 3 cases that presented by Dr. Sơn, it's very useful for us, for, you see, those who work in traumatic department, and also not working there. But from this experience, I think that we support, will help us when we have such kind of the patients. Once more, thank you very much.
Thank you, Professor Hill, for your comment and your recommendation. So, is there any question from the resident doctor? The young doctor, do you have any questions or comment? Dr. Sơn, would you please come back to the last slide, please? Yeah. Conclusion. Yes. I just would like to learn from you the words here. The 2 words, misdiagnosis and misdiagnosis. What is the difference between 2 words? You had to use 2 words, so I think there's something different.
Misdiagnosis means you diagnose wrongly with different disease. And misdiagnosis, you mean you don't diagnose this patient. You can see the patient normal, but it's, in fact they are not normal. Ignore the disease of the patient.
It's very interesting to learn that, because I don't understand. The first one, misdiagnosis, and the second, misdiagnosis. It means that the first one, we think the patient has a disease, but we say the patient has another disease, right? And the second one, it means that the patient is normal.
And understand that.
Are you sure that?
Because I think this
From the
okay report.
Okay review, yeah. I don't know if anyone here can explain to us. Yes, what's the difference between two? I myself, I think it's the same. Yeah. Professor here, can you explain?
The first misdiagnosis, does you think the patient having the disease, but you diagnose wrongly.
Yeah.
The second one, say the patient having disease, but you cannot diagnose, or you ignore. You don't think the patient having the disease. It means you misdiagnosis. Yeah. But the first one, you diagnose wrongly. The second one, you ignore.
But the second one, does it mean that the patient that was diagnosed is diagnosed like a normal people, no disease, or the patient have other disease?
The patient having disease, but you don't think the patient had disease. You ignore the disease. You say, oh, the patient, no, having disease. Say, but the first one, you think, oh, the patient having disease, but you diagnose wrongly to another disease. But the second one, you don't think the patient having the disease.
Thank you. Thank you very much for that. I learned from that. Thank you. Thank you, Professor Hiệp. Thank you, Dr. Sơn, for your very interesting presentation. So
Thank you.
we learned a lot from you. Thank you. So let's move on to the second presentation today. The title of the presentation is the posterior capsular opacification, and it is presented by Dr. Phạm Phương Dung. Please.
Good afternoon, everybody. My name is Dung. I'm a third-year resident doctor, and today I'm so grateful to be here to present a very interesting topic, which is posterior capsular opacification. Firstly, I want to confirm that PCO is one of the most common complications after cataract surgery, and it happens in about from 5 to 10% of patients